this can come as a short note. So take a note and you just see the figure and try to label it. Now definition, the aggregation of lymphatic tissue around the naso-oropharyngeal isthmus constitute Waldeyer's lymphatic ring. Structure, it consists of aggregation of lymphatic follicles covered by mucosa. Location at the commencement of air and food passage, the oropharynx. Now, constituents, nasopharyngeal or pharyngeal tonsil, tubal tonsil, palatine tonsil and lingual tonsil. Now, this is the nasopharyngeal tonsils, this is the tubal tonsils, the tubal opening here. This goes to the Eustachian tube, and this is the palatine tonsil, and this is the lingual tonsil. Now, location of Waldeyer's ring. Now, right lateral view, mid-sagittal section of the head and neck. See, this is the nose, this is the upper lip, this is the lower lip, these are the two incisors, this is the hard palate, this is soft palate, uvula, the palatine tonsils here, and lingual tonsils, this is the tongue, lingual tonsils. Now, here the tubal tonsils here, tubal opening here, and nasopharyngeal tonsil. This is the nasopharyngeal tonsil. Now, Waldeyer's lymphatic ring. Definition, aggregation of lymphatic tissue around the naso-oropharyngeal isthmus. Naso-oropharyngeal isthmus. And lymphatic follicles covered by mucosa. Constituents, nasopharyngeal tonsils, tubal tonsils, palatine tonsils and lingual tonsils. Clinical, adenoid enlarged, nasopharyngeal tonsils. Obstruction of auditory tube, enlarged palatine tonsils, difficulty in swallowing. Now, clinical integration, enlargement of nasopharyngeal tonsils, adenoid may obstruct naropharyngeal air passages. Enlarged tubal tonsil may obstruct auditory tube. Enlarged palatine tonsils may cause difficulty in swallowing. Now, palatine tonsils, see, describe the palatine tonsil under the following headings: morphology, relation, blood supply and applied anatomy. Now, a question on palatine tonsils can come. So, you have to, under these headings, morphology, relation, blood supply and applied anatomy. Palatine tonsils, commonly called tonsils, are a pair of almond-shaped masses or lymphoid tissue situated in the lateral wall of the oropharynx in the tonsillar fossa. These palatine tonsils. This is the uvula, this is the soft palate, this is the hard palate. Now, this is the palatopharyngeal arch, this is the tongue, this is the mandible with the teeth. Now, palatine tonsils are located in the tonsillar fossa. The boundaries of the tonsillar fossa: anteriorly palatoglossal arch containing palatoglossus muscle, posteriorly palatopharyngeal arch containing palatopharyngeus muscle, apex soft palate, meeting point of both the arches, the meeting point of these both arches, and base dorsal surface of the posterior 1/3 of the tongue, lateral tonsillar bed. This even best is that you take a spoon and see your friend's oropharynx and the tonsil and the mouth. Even you can see in yourself and in the mirror, you can get the location, and in the palatine tonsil usually fishbone actually get, when you're swallowing a fishbone, it might get impregnated and stuck there. In the oropharynx and the palatine, the tonsils are a common site. Now, palatopharyngeal arch, the palatoglossal arch, soft palate, this is the uvula, palatine tonsil, posterior wall of pharynx, dorsal surface of posterior 1/3 of the tongue. This you can see in the mirror yourself. Or you open your mouth and see and try to identify, or your friends, you put a spoon and depress the tongue and see the anatomy. Now, palatine tonsil, location in the lateral wall of oropharynx in tonsillar fossa, boundaries, anterior palatoglossal arch, posterior palatopharyngeal arch, apex, soft palate, base, posterior 1/3 of the tongue. Tonsillar bed, a pharyngobacillar fascia, superior constrictor, buccopharyngeal fascia, styloglossus, glossopharyngeal nerve. External features, medial surface, free, lined by non-keratinized stratified squamous epithelium, tonsillar pits 12 to 15, tonsillar crypts, intratonsillar cleft, lateral surface covered by capsule, anterior border related to palatoglossal arch, posterior border related to palatopharyngeal arch, upper pole reach soft palate, lower pole suspensory ligament of the tonsils. Now supply, arterial supply, tonsillar branch of facial artery, ascending palatine branch of facial artery, dorsal lingual branch of lingual artery, ascending pharyngeal branch of external carotid artery, greater palatine branches of maxillary artery. Now venous drainage, paratonsillar vein and pharyngeal plexus. Lymphatic drainage, jugulo-digastric nodes, innervation, glossopharyngeal nerve, greater and lesser palatine branches of pterygopalatine ganglion. Now clinical, tonsillitis, tonsil stones, ear pain in tonsillitis, quinsy, tonsillectomy and postoperative hemorrhage in tonsillectomy. Now tonsillar bed, the palatine tonsil rests on the tonsillar bed which is formed by the following: the pharyngobacillar fascia, superior constrictor muscle, buccopharyngeal fascia, styloglossus, glossopharyngeal nerve. Size and shape, the palatine tonsil is an almond-shaped mass. It is large in children and diminished in size in adults. Its size is much bigger than it appears on oropharyngeal examination due to its upward and lateral extension. That means the now see what I wanted to show you in this figure is that the size and shape. The palatine tonsil is an almond-shaped mass. It is large in children and diminished in size in adults. Its size is much bigger than it appears on oropharyngeal examination due to its upward and lateral extension. Now, upward extension, lateral extension, and it is larger than what you visualize. Now, this what I am trying to say is that you please examine today only your friends' oropharynx and pharynx and the palatine tonsils, and you will clearly get it. Now, when you read the pharynx, the larynx, pharynx, now these muscles, when you read the base of the skull, the stylopharyngeus muscle, styloglossus muscle, all this you have to correlate with each component. Anterior aspect. Now you see relation of palatine tonsil section through the tonsillar fossa. This is the section through the tonsillar fossa like this. It's cut like this. Now you see this is the palatopharyngeus muscle and this is palatoglossus muscle. Now the tongue is here in this level. So the palatoglossus, this is the palatopharyngeus muscle. Now this is the intratonsillar cleft, this is the tonsillar crypts, the palatine tonsil, palatoglossal arch and paratonsillar vein, Pharyngobacillar fascia, this is the green pharyngobacillar fascia, the peritonsillar space, the glossopharyngeal nerve, the styloglossus muscle, buccopharyngeal fascia, superior constrictor. This is superior constrictor. Now external features. Now the external features, the palatine tonsil has two surfaces, medial and lateral, two borders, anterior and posterior, two poles, upper and lower. You can, the descriptive part is this, and the upper and lower pole. Now external features, two surfaces, medial and lateral, two borders, anterior and posterior, two poles, upper and lower. Medial surface, it is free and bulges into the oropharynx. It is covered by non-keratinized stratumate squamous epithelium. The medial surfaces show the following features. The tonsillar pits, these are 12 to 15 small openings. Each pit leads into a mucous tubal called tonsillar crypt, which is surrounded by numerous lymphatic follicles. Intratonsillar cleft, crypta magna. This is the crypta called intratonsillar cleft is known as crypta magna. It is a deep semilunar fissure in the upper part of the tonsil in 40% of the individuals. It represents remnant of second pharyngeal arch. Now, crypta magna. What is crypta magna? It is the remnant of the pharyngeal pouch, second pharyngeal pouch. And intratonsillar cleft, crypta magna, it is a deep semilunar fissure in the upper part of the tonsil in 40% individuals. It represents a remnant of the second pharyngeal pouch. Lateral surface is covered by well-defined fibrous capsule. The capsule is separated from the tonsillar bed by loose areolar tissue of peritonsillar space. Some interesting facts, the capsule of the tonsil is derived from pharyngobacillar fascia. The capsule is firmly adherent to the tongue. It keeps the tonsils in place during swallowing. Tonsillar artery enters the tonsillar bed by piercing the superior constrictor muscle. The palatine, external palatine or paratonsillar vein descends from the palate in paratonsillar space. It pierces the wall of the pharynx and drains into pharyngeal venous plexus. Now, clinical integration. Paratonsillar abscess, it is an accumulation of pus in paratonsillar space due to spread of infection from tonsils. Paratonsillar vein may get injured during tonsillectomy. Now, borders of the tonsils. Anterior border is related to the palatoglossus arch. Posterior border is related to the palatopharyngeal arch. Poles of the tonsils, upper pole, it is related to the soft palate. Lower pole, it is attached to the tongue by fibrous tissue called suspensory ligament of the tonsils. Now, plica triangularis is a vestigial fold of mucous membrane covering the anterior-inferior part of the tonsil. Plica semilunaris is a semilunar fold that arches backwards and covers the upper pole of the tonsil, including the potential space called supratonsillar fossa. Tonsillolingual sulcus, the tonsil is separated from the tongue by tonsillolingual sulcus. Now, blood supply, lymphatic drainage and innervation. Say this is the maxillary artery, this is the external carotid artery, this is the lingual artery, facial artery, ascending palatine artery, tonsillar artery, now ascending pharyngeal artery. Now, the tonsil is supplied by tonsillar branch of facial main source. The facial artery is the tonsillar artery. This is the tonsillar artery. The major part is covered, supplied by tonsillar artery. Ascending palatine branch of the facial artery, dorsal lingual branch of the lingual artery, ascending pharyngeal branches of the external carotid. Now this is maxillary. This is descending palatine, greater descending palatine. This is the dorsal lingual arteries. This is the tonsils. Now, greater palatine branch of maxillary artery. The veins from the tonsils drain into the paratonsillar vein, which opens into the pharyngeal plexus. Lymphatic drainage, the lymphatic from the tonsils drain into the jugulo-digestive nodes. Hence, they are called tonsillar nodes. Now, The jugulo-digestive nodes get primarily enlarged in tonsillitis. Innervation, the tonsil is supplied by glossopharyngeal nerve. Greater and lesser palatine branches of the pterygo-palatine ganglion. Greater and lesser palatine branches of the pterygo-palatine ganglion, glossopharyngeal nerve. Now, chronic tonsillitis, this is the tongue. These are the tonsils, the soft palate. Tonsillitis, the infection and enlargement of tonsils called tonsillitis. Acute tonsillitis is common in school-going children. It is commonly produced by viral infection. Repeated episodes of infection may result in chronic tonsillitis. Now, acute membranous tonsillitis. Acute membranous tonsillitis, this whitish membrane. This is the tongue, the uvula, soft palate. When you examine the tongue, a child is brought to you with high fever, pyrexia. The jugulo-digestive nodes are enlarged and he cannot speak, even he has some breathing problem. Then you examination with the tongue through a tongue depressor and see the tonsils. And you will see that is a membrane covered, that means that is membranous tonsillitis, acute membranous tonsillitis. Now, here these are tonsillolith. This is tonsillolith, right tonsil. Now, tonsil stones are also known as tonsilloliths, are mineralization of debris within the tonsillar crypts. At least in my practice, I have not come across a tonsillar lith. But in routine, like anyone complains of any fever and the upper respiratory tract infection, I do a routine examination of the oropharynx, mouth, tongue, everything. You get many clues, and now the ear pain in tonsillitis, the pain from palatine tonsil is often referred to the ear through glossopharyngeal nerve. Injury to the glossopharyngeal nerve in tonsillectomy results in loss of all sensation in the posterior third of the tongue. Quinsy is the suppuration in peritonsillar space. This abscess is drained by making an incision, the most prominent part of the abscess. Now, quinsy is a very common problem. It used to be a very common problem, but nowadays the use of advent of many drugs, antibiotics and all, it is in the first episode, whenever they are suffering, they are given an antibiotic. Naturally, to some extent, an anti-inflammatory agents. To some extent, you don't encounter so much as previous days. But if you see a case of quinsy, you refer to the ENT surgeon. Now, tonsillectomy, it's a surgical removal of the tonsils. Recurrent tonsillitis may require tonsillectomy. Guillotine methods are commonly used for tonsillectomy. Post-operative hemorrhage tonsillectomy is checked by removal of clot from the site, because clot may prevent retraction of blood. Now, this is the histology. The lining epithelium, tonsillar crypts, lymphatic follicles. Lining epithelium, oral surface, palatine tonsils covered by non-keratinized squamous epithelium. Now, histology of palatine tonsils. You know this. Lining epithelium, non-keratinized stratified squamous epithelium. Tonsillar crypts, invasion of epithelium lined by non-keratinized squamous epithelium. Lymphoid tissue, aggregation of lymphatic follicles supported by reticular fibers. Now, development of the tonsil. Palatine tonsil develops from two sources: endoderm of the second pharyngeal pouch, mesoderm lymphocytes. Endoderm for the second pharyngeal pouch, and mesoderm, endoderm, mesoderm. Now, stages of development. During the third month of development, ventral part of the second pouch proliferates outwards in surrounding mesoderm as several solid pods called tonsillar buds. On degeneration of central cells, tonsillar buds cannulate to form hollow tonsillar crypts. During 3rd to 5th month, lymphocytes aggregates on the mesoderm and surround crypts and form lymphatic follicles. Mesodermal cells condense to form a capsule of the tonsil, and lymphocytes proliferates and form pharyngeal tonsillar bulging. The remnant of the pouch is represented by intratonsillar cleft and tonsillar fossa. In the previous slides, I told you of the second this endoderm of the second pharyngeal pouch. At least if you remember that you are in a hurry, your bell is rung, then you just endoderm, mesoderm and second pharyngeal pouch. When an embryological part, actually, if you mention these 3 points, you will get marks. Now, up to this, next will be your this is the auditory tube or Histology tube. And today, in anatomy practicals, you people will be having revision. But I am leaving because one of my relatives has died. I have to go to Burdwan. You go to the class, you take any organ, especially head, neck. You want to see pharynx, you want to see larynx, you want to see parotid, you want to see thyroid. Please go and see, spend an hour or 2 and then give your attendance and leave. Thank you. You please go attend your class. It's a revision class. So if you want to see specimens, you see specimens of head and neck, not liver, not spleen, not kidney. You see the specimens of head and neck, thyroid, parotid, pharynx, larynx, whatever you want to see. You please go, attend, give your attendance and sit for an hour or 2 and you do your revision. Thank you.